Have you ever really thought about the invisible world all around us? Teeming with these microscopic life forms that, while we don't see them, they can profoundly impact human health globally.
Yeah, absolutely.
We're talking about the kind of organisms that are critically important to understand the stuff you really need to know about, but probably haven't thought much about until now, maybe.
Indeed.
Yeah.
Welcome to the deep dive. Today, we're embarking on a really extensive, highly focused exploration into this fascinating and sometimes, let's be honest, terrifying realm of amebiasis and infection with free-living amoebae.
Right.
You, our listener, have pointed us towards some truly comprehensive medical sources on this. So our mission today is to distill every essential insight, to break down this complex medical information into, truly understandable, actionable knowledge.
Okay.
Our goal is to equip you with a mastery-level understanding, much like an elite professional in the field would possess. We want you to feel like you really get Chapter 223 after this.
That's the plan. So to lay out our journey today, we'll kick off by delving deep into amebiasis. It's this widespread intestinal infection, but it can range from completely silent, totally asymptomatic, to incredibly severe.
Right. A real spectrum.
Exactly. And from there, we'll pivot. We'll look at some much rarer conditions, but truly devastating ones, caused by organisms people sometimes call brain-eating amoebas and other related free-living conditions.
And we're going deep. For each of these, we'll cover the core definitions, trace their intricate life cycles, map out their global reach. Where are they? Who's most at risk? We'll understand precisely how these parasites attack and damage the human body, explore their diverse clinical presentations, how they actually look in patients.
Yeah.
We'll dissect the sophisticated methods used for diagnosis, which can be tricky. And finally, detail the critical strategies for effective treatment and, importantly, prevention.
So why is this level of detail, this mastery level, crucial for you, the listener?
Well, whether you're maybe a seasoned traveler navigating new environments, or perhaps a healthcare professional aiming to sharpen your diagnostic acumen, or honestly, just someone inherently curious about this unseen world that constantly interacts with and impacts global health.
Right.
Understanding these nuances is absolutely crucial. It's about recognizing subtle symptoms that might otherwise be missed. It's about appreciating the profound complexities involved in getting an accurate diagnosis.
Yeah, which sounds key.
And grasping the challenges that arise in both treating and preventing these sometimes elusive, often severe infections. This deep dive is genuinely designed to elevate your understanding to that of an elite professional in this space.
Unpacking amebiasis, the silent colonizer, and potentially deadly invader.
All right, let's begin our deep dive then with amebiasis. Now, we often hear it described as a spectrum of conditions. So to get that mastery level understanding, what exactly are we talking about when we refer to amebiasis?
Okay, so at its core, amebiasis is an infection caused by Entamoeba histolytica. That's a specific type of protozoan, a tiny single-celled organism.
Yep.
Different from bacteria or viruses, it can move independently.
Right.
Now, the fascinating and frankly challenging aspect here is its huge range of impact. A vast majority of cases, we're talking around 90%, involve what we call asymptomatic colonization.
Meaning people just carry it.
Exactly. They carry the parasite in their gut without experiencing any noticeable symptoms at all. But crucially, even without symptoms, they can still shed the infectious form and transmit it to others. That's a key public health issue.
Okay.
However, for the remaining, say, 10% of infected individuals, the parasite becomes an active invader. It starts causing symptomatic disease.
So when it does become invasive, what does that look like clinically? How does it manifest when it's actually causing problems?
When it turns invasive, E. histolytica primarily causes intestinal colitis. Now, this can range from persistent, severe diarrhea to full-blown dysentery. Dysentery is characterized by frequent bowel movements, often containing blood and mucus, sometimes with very little actual fecal material.
Okay, nasty.
Yeah. But the danger doesn't stop there. This parasite has the ability to go beyond the intestines. We call that extraintestinal amebiasis.
Right.
The most common place for this distant infection is the liver. It forms abscesses. They're basically pockets of dead tissue. Less commonly, it can involve the lungs or, in very rare, devastating cases, even the brain.
Wow.
This wide range of presentations. It's a significant challenge for clinicians trying to diagnose it quickly and accurately.
That's quite a remarkable journey for something microscopic. How do people even get this infection in the first place? Let's trace the full journey of this tiny invader, from out there in the environment to inside the human body.
Okay. So, E. histolytica is acquired through a pretty direct route. You ingest viable cysts.
Yes.
These cysts are the dormant protective stage. They're incredibly resilient. They have this tough wall that lets them survive harsh conditions outside a host body. You typically find them in water or food that's been contaminated with feces, or even directly on hands that have touched contaminated surfaces or, well, feces. Their resilience is key to how widely it spreads.
So food is a major route of transmission then. Is that the main way?
Absolutely. Foodborne exposure is by far the most prevalent form of transmission globally.
How does that happen?
Often, it's when food handlers are themselves asymptomatic carriers, shedding cysts in their stool without knowing it. Or, critically, when food is grown using water or fertilizers contaminated with human feces. This is a massive public health challenge, especially in areas with poor sanitation.
Right, I can see that. Are there any other, maybe less obvious ways this parasite can spread?
Yes, there are a few less common routes. It's also been linked to direct person-to-person transmission, specifically through oral and anal sexual practices.
Okay.
And in very rare instances, there have been documented cases of direct rectal inoculation through contaminated colonic irrigation devices. It just highlights the importance of hygiene and safe practices across the board.
Once these cysts are ingested then, what exactly happens inside the body? How does this journey unfold, say, in the small intestine and beyond?
Okay, so once ingested, the cysts travel down to the small intestine. There, they undergo a process called excistation.
Excistation.
Yeah, the cyst wall breaks open, releasing the motile, active forms of the parasite. These are called trophozoites.
Prephazoids, got it.
Now, for the vast majority of patients, these trophozoites just remain harmless commensals, meaning they live peacefully within the lumen, the inside space of the large bowel, without causing any trouble.
Okay.
After maturing a bit, they insist, again, forming new, highly infectious cysts. These new cysts are then shed in the stool, and they're tough. They can survive for several weeks in a moist environment, just waiting to continue the cycle.
But as we said, some people get really sick. Where does the invasion happen for those individuals who develop symptoms?
Right. So in that critical subset of patients, these trophozoites don't just stay put in the gut lumen. They actively invade the bowel mucosa, that's the lining of the large intestine. That directly leads to symptomatic colitis. That's where you see the dysentery, the severe abdominal pain. Or, even more alarmingly, they can breach the gut barrier entirely and enter the bloodstream.
Okay, that sounds bad.
It is. Once in the bloodstream, they can travel to distant organs. Predominantly, they cause those abscesses in the liver, but also, as we noted, sometimes the lungs, or very rarely the brain.
And I've heard the term hematophagus trophozoites.
Yeah.
What are those? Why are they significant, especially for diagnosis?
That's a crucial detail, especially for clinical professionals trying to get a definitive diagnosis. In patients who are experiencing active dysentery, so severe bloody diarrhea, these specific trophozoites are often found in fresh stool samples.
Okay.
What makes them hematophagous is that they have literally ingested red blood cells. You can sometimes see the red cells inside them under the microscope. It's a key sign of active invasive disease. It's also vital to remember that these trophozoites, the active form, are very fragile outside the body. They're rapidly killed by exposure to air or water or stomach acid. They can't directly transmit infection once they're shed. It's the resilient cyst that's the primary infectious form, the one responsible for perpetuating the cycle.
Got it. So shifting our view to the global landscape then, where is Amebiasis histolytica a major concern? Which populations are most vulnerable?
Histolytic infection predominantly affects underdeveloped tropical regions, areas characterized by poor sanitation systems and inadequate hygiene.
Makes sense.
It's particularly widespread in places like the Indian subcontinent, large parts of Africa, certain areas of East Asia like Thailand, and extensively throughout Central and South America. Mexico and Colombia are often highlighted.
And within those areas?
Children under 5 years old are especially vulnerable, often due to their developing immune systems and, frankly, higher rates of environmental exposure through playing or drinking unsafe water.
That paints a very clear picture of where this infection is endemic. What's the actual human toll? The impact of this widespread prevalence?
The human cost is undeniably significant. According to the Global Burden of Disease 2016 study, which is a huge undertaking, Amebiasis was directly responsible for over 26,000 deaths worldwide across all ages.
Wow.
And a particularly tragic part of that is the more than 4,500 deaths among children under 5.
That's awful.
It is. And it raises an important question. Given how widespread it is and the mortality it causes, why does this infection persist at such high levels? What are the broader global health implications for development, for well-being, especially for the youngest kids?
Yeah. And in developed countries, is it solely a traveler's disease, or are there specific groups at risk domestically too?
In developed countries, the picture shifts quite a bit. While it's certainly not exclusively a traveler's disease, travel is a significant factor. Key risk groups include returning travelers, especially those who've been on long-term trips, say, more than 6 months. Data from the Geosentinel surveillance network they tracked travel-related illnesses showed that among these long-term travelers, diarrhea due to E. histolytica was actually one of the most common diarrheal diseases they picked up.
Interesting.
Beyond travelers, other groups with elevated risk include recent immigrants from endemic areas, men who have sex with men, MSM, military personnel, and also individuals in institutional settings like prisons where close contact and potential hygiene lapses can occur. For instance, Japan saw an uptick in cases among HIV-positive patients, particularly within the MSM population, so it's not just travelers.
So when we put this into a global context, how does E. histolytica rank among parasitic infections in terms of how deadly it is?
Worldwide, E. histolytica holds a pretty grim distinction. It's the second most common cause of death related to parasitic infection, ranking right after malaria.
Second only to malaria. That really puts it into perspective.
It does. It underscores its profound and, frankly, often underestimated impact on global health.
And there's even a noticeable gender difference in how the disease manifests. Can you explain that? That seems unusual.
Yes, that's a fascinating and clinically important observation. Invasive colitis and especially liver abscesses are significantly more common. We're talking about 10 to 12 times more frequent among men than women.
10 to 12 times. Why?
Well, this notable disparity has been attributed to a couple of factors. Differences in complement-mediated killing, that's part of our innate immune system, and also the effects of testosterone on the secretion of interferon gamma, a key immune signaling molecule.
So hormones play a role.
It appears so. It highlights how intrinsic host factors, like hormones, can really influence susceptibility and the outcome of the disease.
We focus heavily on E. histolytica, but what about these other Entamoeba species, like E. dispar, E. moshkowski, or E. bangladeshi? Do they cause the same problems, or are they different? This feels like a critical distinction for professionals to master.
This raises an absolutely crucial point for accurate diagnosis and therefore proper management. That wide spectrum of clinical disease we see with Entamoeba is partly because of the differences between E. histolytica and other species, particularly E. dispar.
Good.
Now here's the challenge. E. histolytica and E. dispar look virtually identical under a standard microscope. Morphologically, they're very hard to distinguish.
Right.
But E. histolytica has unique surface antigens, it's genetically distinct, and critically, it possesses specific virulence properties, the ability to actually cause disease that E. dispar lacks.
So E. dispar is harmless then?
Essentially, yes. It's considered non-pathogenic. Most asymptomatic carriers, including groups like MSM and patients with AIDS, actually harbor E. dispar. It causes self-limited infections, maybe mild symptoms sometimes, but it is fundamentally incapable of causing invasive disease like colitis or liver abscesses.
Okay.
This is a key differentiator. It stands in stark contrast to other gut pathogens that can be devastating for immunocompromised hosts. Knowing which species is present is vital.
And newer species have been identified recently too, using more advanced techniques, right?
Yes, exactly. Through advanced genomic sequencing, we've identified E. moshkowski and E. bangladeshi. And like E. dispar, they are also microscopically indistinguishable from E. histolytica.
Do they cause disease?
Well, E. moshkowski has been shown to cause diarrhea and colitis in mice models. Human cases, however, often involve co-infection with other known gut pathogens, making it really challenging to pinpoint its sole contribution to disease.
I see.
E. bangladeshi was first reported in 2012 in Bangladesh, but has also popped up in South Africa. Honestly, we urgently need more clinical and epidemiologic studies to figure out their true role in human disease and whether they have any invasive potential. This field is still actively evolving.
Okay, this is where it gets really fascinating for me. How do these tiny organisms, specifically the E. histolytica trophozoites, actually cause such profound damage once they decide to invade? What's happening at that microscopic cellular level?
It truly is fascinating. It's like a sophisticated assault from a single-celled organism. Remember, both trophozoites and cysts are found in the gut, but critically, only the E. histolytica trophozoites have the capability to invade host tissue. And these trophozoites are quite large, microscopically speaking, with distinct internal structures.
So how do they even get a foothold in the first place? What's their initial strategy to breach our defenses, like the gut lining?
Their first move is attachment. They use a highly specific protein on their surface. It's called the galgalnac adherence lectin. Think of it like molecular Velcro.
Okay.
They use this lectin to latch onto the colonic mucus layer and the epithelial cells lining our intestines. Once attached, they unleash a kind of chemical arsenal. Enzymes like glucosidases and proteases.
What do those do?
They start degrading the mucus polymers, essentially breaking down that protective slimy barrier that lines our gut. And beyond that, they deploy even more destructive enzymes called cysteine proteinases.
More enzyme.
Yes, and these are particularly nasty. They degrade vital host proteins, things like collagen and elastin, which provide structure to our tissues. They even degrade key immune components like IgA and IgG antibodies and parts of our complement system, basically disarming our local defenses.
Wow. So they literally break down our defenses. And what's the next stage of their attack?
After disrupting that mucus layer, the trophozoites inflict damage on the underlying mucosa, the gut lining itself, through two main mechanisms: contact-dependent and contact-independent cytotoxicity.
Okay, break those down. Contact-dependent.
Contact-dependent is pretty direct. It involves inducing programmed cell death, or apoptosis, in our host cells. They also do this truly remarkable thing called trogocytosis.
Trogocytosis, what's that?
It means they literally nibble or ingest fragments of living host cells, not just dead ones. Yeah. And furthermore, they cause lysis bursting of our frontline inflammatory cells like neutrophils, monocytes, lymphocytes, as well as the actual gut lining cells and liver cells. They do this by releasing substances like phospholipase A and pore-forming peptides, which essentially punch holes in the host cell membranes.
Okay, that's brutal. And contact-independent damage.
That follows the production of inflammatory mediators by the trophozoites themselves, things like prostaglandin E2. This causes an increase in the permeability of the intercellular tight junction.
The seals between cells.
Exactly. Those seals maintain the integrity of the gut lining. When they become leaky, the barrier is compromised, further allowing the parasite to invade and cause more widespread damage. It's really a multi-pronged assault strategy.
They sound incredibly resilient. How do they survive the body's own attempts to fight them off? Like the reactive oxygen and nitrogen species our immune system produces during an invasion. Those are supposed to kill invaders, right?
They are. And that ability to resist our body's oxidative and nitrosative defenses, molecules like hydrogen peroxide and nitric oxide, which our host cells pump out during tissue invasion, is indeed a key virulence factor for E. histolytica. It's how they evade being killed by our own immune response.
Gotta do it.
What's truly fascinating here is that E. histolytica lacks the typical antioxidant systems that our cells have, like glutathione. Instead, it relies on its own unique defense system, specifically something called the thioredoxin reductase system.
Okay.
This system is remarkably versatile. It can neutralize various reactive species and even use alternative energy sources. This unique biochemical pathway is a critical insight into their survival strategy and actually a potential drug target.
And our primary treatment, metronidazole, how does that work then if this is their unique defense system?
Metronidazole seems to exert its antiparasitic effect precisely by inhibiting this unique thioredoxin reductase antioxidant system within the parasite.
Targets their defense.
Exactly. By knocking out this essential survival mechanism, the drug effectively renders the parasite vulnerable to the host's own oxidative defenses and even its own metabolic byproducts. It leads to its demise.
Sure.
And there's a fascinating development on this front, too. A drug called Aranafin, which is already approved for rheumatoid arthritis, also inhibits thioredoxin reductase. It's currently undergoing clinical trials against both E. histolytica and another parasite, Giardia. It points to potentially repurposing existing drugs.
Interesting. What about their interaction with the gut microbiome? Do they actually eat bacteria?
Yes. Phagocytosis, the ingestion of other cells or particles, is another significant virulence factor for these trophozoites. In fact, if you inhibit this process, it messes up their ability to proliferate.
So they need to eat bacteria.
They use membrane-associated carbohydrate-binding proteins to specifically phagocytose or eat intestinal bacteria, especially gram-negative ones like Enterobacteriaceae, for nutrients. But here's where it gets even more complex and nuanced. The type of bacteria they encounter profoundly matters. Interactions with certain commensal or good bacteria, like some strains of Escherichia coli, can actually attenuate, meaning weaken the virulence of E. histolytica.
Oh,
By decreasing the expression of that critical galgalnac lectin, the attachment protein we talked about. So a healthy, balanced microbiome could potentially dampen the parasite's aggressiveness.
so good bacteria can weaken them. What about bad or disease-causing bacteria? Do they make the amoeba more dangerous?
In contrast, yes. Ingesting enteropathogenic bacteria like certain virulent E. coli strains or Shigella dysenteriae, which causes bacterial dysentery, actually has the opposite effect.
It makes them stronger.
It increases the expression of the galgalnac lectin and enhances the activity of those destructive E. histolytica cysteine proteases. It makes the amoeba significantly more dangerous and invasive. This is a complex interplay, a three-way conversation between the parasite, the host, and the microbiome. Professionals really need to consider co-infections.
That's a really complex interaction.
Yeah.
Do they also change the overall gut environment and the balance of the microbiome itself?
Yes, they do. E. histolytica is quite capable of altering the composition of the commensal gut microbiota. A study in northern India found that adult patients with amoebic dysentery for about a week showed significant decreases in beneficial bacteria like bacteroids, certain Clostridium subgroups, Lactobacillus, Campylobacter, and Eubacterium.
And increases.
Simultaneously, they showed increases in Bifidobacterium, so it indicates a measurable dysbiosis and imbalance caused by the infection, potentially creating an environment that's even more favorable for the parasite itself.
And for children, especially in those areas where infection is common and really impacts development,
Right.
what have we learned about the microbiome's role there?
In that community study in Bangladesh, where a large percentage of kids get infected by age 2, they found something crucial. A specific gut antibody called fecal anti-galgalnac lectin IgA was significantly associated with protection from reinfection.
So the gut learns to fight it.
It indicates the gut develops a protective local immune response. However, they also found that a high parasite burden in the first year of life was linked to two critical outcomes: the expansion of a specific bacterium called Prevotella in their gut, and the direct presence of diarrhea. This raises a really important question for future research in clinical practice. How does that early life microbiome development influence a child's susceptibility to amebiasis and how severe it gets? It suggests a very delicate, crucial balance early on.
What about the immune system's more direct response beyond antibodies?
Yeah.
Do specific antimicrobial peptides or body's sort of natural antibiotics play a role?
Yes, they do. Antimicrobial peptides like cathelicidins are an important part of our innate immunity, that immediate nonspecific defense. These peptides are actually induced by E. histolytica during intestinal invasion. This was shown nicely in a mouse model.
Oh, interesting.
In the model, the amount of cathelicidin mRNA in the cecum part of the large intestine increased dramatically, over 100-fold in just 7 days.
Wow, so the body really ramps up production.
It does. But despite this strong host response, E. histolytica remarkably remained resistant to being killed by cathelicidin.
How?
It's likely because the parasite's own highly effective cysteine proteinases, those destructive enzymes, again actively digest and degrade the antimicrobial peptide, rendering it useless. It's like a constant arms race. And the parasite has evolved these clever counter strategies.
So it actively fights back against our natural defenses?
Right.
What about acquired immunity, like the specific antibodies produced after we've been exposed? Do they offer protection?
IgA plays a critical role, especially in the gut. That study in Bangladeshi schoolchildren provided compelling evidence, an intestinal IgA response to the galgalnac lectin, that attachment proteins significantly reduce the risk of getting a new E. histolytica infection by about 64%.
That's huge.
It really highlights the importance of localized gut immunity. Interestingly, though, and this is a key distinction for professionals, serum IgG antibody, the kind found circulating in the bloodstream, is not protective. Yeah. In fact, its levels tend to correlate more with how long someone has been ill, rather than how severe the disease is. Even more surprisingly, those Bangladeshi children who had a serum IgG response were actually more likely to develop a new E. histolytica infection.
More likely, how does that work?
It suggests that systemic IgG doesn't confer protection. and might even just be a marker of chronic exposure or past infection, rather than indicating true effective immunity against reinfection.
And for very young infants, what kind of protection do they get, if any?
For infants in that same Bangladeshi community, passive immunity, the kind you get from your mother, conferred by a maternal parasite-specific IgA delivered via breastfeeding, proved highly beneficial.
How beneficial?
It resulted in a significant reduction, around 39%, in the risk of getting infected in the first place, and a substantial 64% reduced risk of developing diarrheal disease from E. histolytica during that critical first year of life.
Wow, so breastfeeding is really protective.
It underscores the protective power of breast milk and maternal antibodies. However, this protection seemed to be species-specific. It offered little or no protection against infections with those other Entamoeba species like E. dispar or E. bangladeshi.
Are there genetic factors that make some people more susceptible to severe amebiasis than others?
Yeah.
This sounds like such a complex interaction between host, parasite, and environment.
Yes, absolutely. That Bangladeshi cohort has been instrumental in helping us understand genetic susceptibility. For example, a specific genetic variation in a part of our immune recognition system, the MHC class II allele DQB10601, was found to protect against amoebic intestinal disease.
Okay.
This strongly supports the idea that how our body processes antigens and the role of specific T cells are crucial in resistance. Another fascinating finding relates to our body's leptin receptors.
Leptin, like the hormone involved in appetite.
Exactly. But these receptors are also expressed on intestinal epithelial cells. They play roles in preventing cell death, promoting tissue repair, and maybe decreasing inflammation. A tiny genetic change, a single amino acid substitution in these receptors, nearly quadrupled the risk for amoebic intestinal disease in children, and also increased the risk for amoebic liver abscesses in adults.
Quadrupled the risk from one tiny change.
Yeah. It shows how subtle genetic differences can have a massive impact on disease outcome.
Any other genetic links discovered that might shed light on this susceptibility?
Similarly, variations in another genetic locus called CREMCUL2 might increase the risk for diarrhea, specifically in children who acquired E. histolytica within their first year of life. Interestingly, both of these genetic variations, the leptin receptor 1 and the CREM1, are overrepresented in this particular geographical region. It highlights how local genetic diversity can shape disease patterns. Furthermore, these CREM variations are also associated with inflammatory bowel disease, suggesting this gene might regulate the delicate balance between the gut microbiota and the intestinal immune response, implying a shared underlying vulnerability.
Beyond the cellular damage and immune interactions, what about the actual physical damage E. histolytica causes to the intestines? The kind doctors might see during an examination, like a colonoscopy.
Okay, the earliest intestinal lesions are typically microulcerations, very small erosions in the mucosa, the lining, usually in the cecum, sigmoid colon, or rectum. These initial breaches lead to the release of red blood cells, inflammatory cells, and bits of epithelial cells.
What do they look like?
On a colonoscopy, they might appear as distinctive, small, sort of pinpoint lesions, often described as having a central yellow dot.
And what about the famous flask-shaped ulcer? That's the one everyone learns about.
That's the classic, almost pathognomonic sign, the hallmark of invasive amebiasis. The flask shape results from the trophozoates extending their invasion laterally, burrowing under the surface mucosa into the submucosa, while the surface might still look somewhat viable.
So it tunnels underneath.
Exactly. And the trophozoates themselves are found right at the margins where the living tissue meets the dead tissue, actively destroying cells. Now, unlike many bacterial infections which cause massive inflammation, human intestinal amebiasis is often characterized by a paucity of inflammatory cells, meaning very few neutrophils or other immune cells are actually in the lesion.
Why is that?
It's likely because, as we discussed, the trophozoites actively kill neutrophils, effectively subverting the host's inflammatory response right at the site of invasion.
Do these ulcers heal well after treatment, or do they leave lasting damage or scars?
Treated ulcers typically heal remarkably well, often with little to no scarring, which is good news. However, in rare, very severe cases, the infection can progress to full-thickness necrosis, death of the entire bowel wall, and even perforation, a hole, which is obviously a life-threatening surgical emergency.
And what about something called an amidoma? That sounds like a tumor or a mass?
Rarely, yes. Intestinal infection can lead to the formation of a localized mass lesion within the bowel lumen. We call that an amoeboma. The lining over these lesions is usually thin and ulcerated, while the deeper layers of the bowel wall become thickened, swollen, and often hemorrhagic.
What causes the mass?
It results from an exuberant formation of granulation tissue that's healing tissue, but interestingly, with very little fibrous response, unlike a typical tumor. These can be easily confused with cancerous growths on imaging, which makes getting a definitive diagnosis, often through biopsy, critically important to avoid unnecessary surgery.
Now, shifting to the liver. When the infection goes there, which you said is the most common extraintestinal site, what happens? And does that gender disparity we talked about still hold true for liver abscesses?
Yes, absolutely. Amoebic liver abscesses show that same striking age and gender dependence. Men between 30 and 60 years old are most commonly infected, at a rate significantly higher, about 10 to 12 times higher than women in the same age group.
And the testosterone link.
Studies in animal models strongly suggest that testosterone may indeed increase susceptibility, possibly by modulating the secretion of interferon gamma by certain immune cells, which are activated by E. histolytica's surface molecules. It's a very clear example of how host biology influences disease outcome.
How exactly do these trophozoites manage to get from the intestines all the way to the liver?
Okay, so the trophozoites invade the tiny veins within the intestinal wall. From there, they reach the liver through the portal venous system. That's the network of veins that drains blood directly from the intestines to the liver. Early on, the blood vessels themselves can be damaged by the amoeba lysing their walls and causing blood clots to form. Crucially, E. histolytica possesses this remarkable resistance to complement-mediated lysis. Complement is a key part of our innate immune system in the blood designed to kill pathogens.
So they can survive in the blood.
Their resistance to complement is absolutely critical for their survival in the bloodstream and their ability to spread to distant organs like the liver. It makes them a truly formidable invader.
And once they're actually in the liver, what's the damage that occurs to the liver tissue itself?
In animal models, what we see is that the initial arrival of the amoebae triggers an acute cellular infiltrate, mostly neutrophils, our immune system's first responders, rushing to the site.
Right.
However, these neutrophils are then lysed, destroyed by direct contact with the amoebae. And ironically, the release of toxins from these dying neutrophils may actually contribute to the necrosis, the death of the hepatocytes, the main liver cells.
So the immune response backfires a bit.
It seems to contribute to the damage, yes. The liver tissue, the parenchyma, is progressively replaced by this necrotic material. It's typically surrounded by a thin rim of congested, often inflamed liver tissue at the edge of the abscess.
Is that the anchovy paste consistency I've heard about when they drain an abscess?
Yes, precisely. The necrotic contents of a classic amoebic liver abscess are described as having the consistency and appearance of anchovy paste, though the fluid's color can actually be quite variable.
What's in it?
It's composed of bacteriologically sterile granular debris, meaning there are usually few or no live bacteria and very few or no intact host cells left. Now, this is a critical diagnostic detail for professionals.
Okay.
If amoebae are seen in a sample, they tend to be found near the capsule or the wall of the abscess where the active invasion is still happening, not in the readily aspirated necrotic center.
So just draining the middle might miss them.
Exactly. That's why aspirating the center of an abscess might yield a negative result for amoebae, even if it is an amoebic abscess. Biopsies of the wall are often more fruitful, though riskier.
So now that we understand the intricate mechanics, if someone is infected with amebiasis, what are the actual symptoms they might experience? From the mildest form to the most severe, life-threatening ones.
Okay, well, the most common scenario, as we emphasized earlier, is completely asymptomatic cyst passage. Many individuals, even in highly endemic areas, might harbor E. dispar without symptoms, or even pathogenic E. histolytica can just colonize without causing illness for a while.
But for those who do get sick with intestinal amebiasis, what's the typical progression like?
Symptomatic amoebic colitis usually develops about 2 to 6 weeks after ingesting the infectious cysts. The onset is typically gradual. It might start with some lower abdominal pain and mild diarrhea.
Okay.
This then progresses to more generalized symptoms like malaise, just feeling unwell, maybe some weight loss, and a more diffuse lower abdominal or back pain. If the infection primarily involves the cecum, that first part of the large intestine, its presentation can even mimic acute appendicitis.
Right, that could be confusing.
It's very confusing for clinicians initially.
And for someone with full-blown dysentery from amebiasis, what would that look like?
Patients with full-blown amoebic dysentery might experience really frequent bowel movements, sometimes 10 to 12 times a day. And these stools, as we said, typically contain very little fecal material and consist mainly of blood and mucus.
Hmm.
Now, a key differentiator from many bacterial diarrheas is that fewer than half of patients with amoebic dysentery are actually febrile. They might not have a significant fever. However, virtually all patients will have heme-positive stools, meaning there's blood present, even if it's not visible to the naked eye.
Are there even more severe sort of fulminant forms of intestinal disease?
Yes, there are, though thankfully they're rare. More fulminant intestinal infection is characterized by severe abdominal pain, high fever, and profuse diarrhea. This tends to occur predominantly in children.
And the complication?
These patients can rapidly develop a life-threatening complication called toxic megacolon. That's where the bowel becomes severely dilated, paralyzed, and you can see air within the bowel wall itself on imaging. It indicates profound tissue damage, and it's a true medical emergency.
I understand there's a really crucial connection between amebiasis and the use of steroids or glucocorticoids. Can you explain that link and why it's so important for clinicians to be aware of?
This raises an incredibly important point for clinicians, absolutely critical. Patients who are receiving glucocorticoids steroids for any reason are at significantly increased risk for severe amebiasis.
Why is that relevant?
Well, this association emphasizes the crucial importance of excluding amebiasis whenever inflammatory bowel disease, or IBD, like Crohn's or ulcerative colitis, is suspected.
Oh, because steroids are used for IBD.
Exactly. Treating undiagnosed amebiasis with glucocorticoids, which suppress the immune system, can lead to devastating complications like triggering toxic megacolon or even causing bowel perforation. So the rule is, for any patient with suspected IBD, especially in relevant geographic areas or with risk factors, always rule out amebiasis first before starting steroids.
What if amebiasis presents not as diarrhea, but as a mass, that of meboma you mentioned?
Occasionally, yes. A patient might present not with dysentery, but just with an asymptomatic or maybe tender abdominal mass. This is caused by an amoeba. And on imaging studies like barium enemas, it can be easily confused with cancer.
So how do you tell?
In this setting, getting a positive serologic test for E. histolytica antibodies, or even better, a biopsy of the mass that confirms the presence of the amoeba, is absolutely vital to prevent unnecessary and potentially harmful surgery for suspected cancer.
You also mentioned environmental enteropathy and its specific link to children. Can you elaborate on that impact? It sounds quite serious for development.
Environmental enteropathy, sometimes called tropical enteropathy or impoverished gut, is a condition characterized by blunted small intestinal villi, those finger-like projections that absorb nutrients and inflammation in the underlying tissue.
Where does that happen?
It's widely observed in tropical developing areas where endemic enteric infections, including amebiasis, are common. This condition is significantly associated with functional gastrointestinal impairment. Basically, the gut doesn't work properly, leading to malnutrition and stunted growth in children, particularly within their first 2 crucial years of life.
What was the specific impact observed in children in Bangladesh, for example? You mentioned those studies.
Right. In those Bangladeshi studies, children who had symptomatic E. histolytica infections were found to be significantly more likely, nearly 3 times more likely to be malnourished, and strikingly, almost 5 times more likely to be short for their age compared to uninfected children in the same community.
5 times more likely to be stunted.
Yes. And these physical growth impairments have cascading effects. They significantly affect a child's cognitive development and, looking long-term, may be linked to a profound loss of productivity in adulthood. It's a critical insight into the long-term societal and economic impact of chronic parasitic infections like amebiasis, extending far beyond just the acute diarrheal illness.
Let's shift our focus now to liver abscesses, the most common form of extraintestinal amebiasis. How do those usually present clinically? What should doctors look for?
Okay. Extraintestinal infection most often involves the liver. Now, for travelers who develop an amoebic liver abscess after returning from an endemic area, about 95% will do so within 5 months of leaving the region. That's a useful time frame.
And the presentation.
Younger patients typically present in a more acute phase, prominent symptoms lasting less than 10 days. Most of these patients will have a fever and experience right upper quadrant pain.
What kind of pain?
It can be dull or pleuritic, meaning it worsens with breathing. Sometimes it radiates up to the right shoulder. Tenderness when pressing over the liver is common, and sometimes you see a right-sided pleural effusion of fluid around the lung. Jaundice, yellowing of the skin, is surprisingly rare, which helps differentiate it from some other liver problems.
And is active diarrhea usually present if the infection started in the colon? That seems like a common assumption people might make.
That's a crucial point, and it's a common misconception even among some professionals. Despite the colon being the initial site of infection, fewer than 1/3 of patients who present with an amoebic liver abscess actually have active diarrhea at the time of presentation.
Only a third.
Okay. This makes the diagnosis even more challenging because those typical gut symptoms you might expect are often absent.
What about older patients, maybe from endemic areas? Do they present differently?
Yes, older patients from endemic areas are more likely to have a more subacute course, meaning symptoms develop more slowly, maybe lasting up to 6 months. They often present with things like weight loss and an enlarged liver, hepatomegaly. About 1/3 of these patients with more chronic presentations will also have a fever.
So it can be quite subtle then.
Exactly. It demonstrates how challenging diagnosis can be, especially in older individuals or those with a more drawn-out illness, because the symptoms are often nonspecific and can mimic many other conditions, like malignancy.
So if someone has a fever of unknown origin, this should definitely be on the list of possibilities then.
Precisely. Since a significant chunk, about 10–15% of patients with amoebic liver abscess present only with fever, without any other clear localizing signs, amoebic liver abscess must always be considered in the differential diagnosis of fever of unknown origin, especially, of course, in individuals with relevant travel history or other risk factors. It's a key zebra diagnosis that astute clinicians, those elite professionals, must keep in mind.
What are the most serious complications that can arise from a liver abscess? Where can it go wrong?
Pleural pulmonary involvement, meaning complications affecting the lungs and the space around them, the pleural space is the most frequent complication, reported in about 20–30% of patients.
What does that involve?
Manifestations can include sterile effusions, where fluid accumulates around the lung without being infected itself, contiguous spread, where the abscess directly erodes from the liver into the lung tissue, or, more severely, frank rupture of the abscess directly into the pleural space.
How are those managed?
While sterile effusions and contiguous spread usually resolve with just the medical therapy for the amoeba, a direct rupture into the pleural space absolutely requires drainage, usually with a chest tube.
And what about something called a hepatobronchial fistula? That sounds particularly dramatic.
That's indeed a dramatic complication.
Yeah.
A hepatobronchial fistula forms when a liver abscess ruptures directly into a bronchus, one of the airways in the lung. It creates a direct connection between the liver abscess and the airway.
What are the symptoms?
It can cause a cough productive of large amounts of necrotic material, often described as foul-smelling, sometimes like anchovy paste. And that material may actually contain amoebae. Despite how dramatic and alarming it sounds, it actually carries a surprisingly good prognosis once identified and treated correctly.
What about rupture into the abdomen? Or, even more critically, into the heart sac, the pericardium?
Rupture into the peritoneum, the lining of the abdominal cavity, can present either as an indolent slow leak causing localized pain, or as an acute abdomen, a surgical emergency with sudden severe pain. Both scenarios require prompt percutaneous catheter drainage of the fluid collection and the standard medical therapy.
And the heart.
The gravest prognosis, however, comes from rupture into the pericardium. This usually originates from abscesses located in the left lobe of the liver, which sits right next to the heart. This can occur even during medical therapy, which is frightening. It necessitates urgent surgical drainage to prevent cardiac tamponade, life-threatening compression of the heart, which can rapidly lead to death. This is the complication everyone fears most.
Can amebiasis spread to other parts of the body too, beyond the intestines, liver, and lungs?
Less commonly, yes. The genitourinary tracts can become involved. This can happen either by direct extension from a nearby infection in the colon or by hematogenous spread through the bloodstream.
What does that look like?
It can cause painful genital ulcers, which often have a distinctive punched-out appearance and produce a profuse discharge. These can be quite distressing, but typically respond well to medical therapy. Cerebral involvement, infection of the brain, is very rare, reported in fewer than 0.1% of patients in large clinical series.
And if it does go to the brain?
The symptoms and prognosis of cerebral amebiasis depend entirely on the size and specific location of the lesion within the brain. but it's exceptionally rare.
Okay. Given such varied and often nonspecific presentations, how do doctors actually diagnose amoebiasis? What are the key diagnostic tests and clues they look for to gain that definitive mastery-level insight?
For diagnosing amoebiasis, the most important procedures involve really a three-pronged approach. Careful stool examinations, specific serologic blood tests for antibodies, and non-invasive imaging, especially of the liver when an abscess is suspected. Using these methods in combination is crucial for accurate identification.
Let's start with stool tests. What specific clues do they provide that point towards amoebic colitis?
Okay. Fecal findings that strongly suggest amoebic colitis include, firstly, a positive test for heme, indicating the presence of blood, which might be microscopic. Secondly, and crucially, there's often a paucity of neutrophils, those white blood cells in the stool.
Unlike bacterial infections.
Exactly. That's a very distinct finding compared to most bacterial diarrheas, which typically show sheets of neutrophils. And of course, the microscopic presence of amoebic cysts or the trophozoites themselves. The definitive diagnosis of active amoebic colitis is specifically made by demonstrating those hematophagous trophozoites of E. histolytica, the ones that have visibly ingested red blood cells.
I recall you said trophozoites are quite fragile. Is that an issue for diagnostic purposes? Does it impact how samples need to be handled?
Absolutely. Their fragility is a significant practical issue. Because trophozoites are rapidly killed by exposure to water, drying, or even barium from imaging studies, it is critically important to examine at least 3 fresh stool specimens.
Fresh meaning.
Meaning examined very quickly after collection, ideally within an hour, or preserved in special fixatives immediately. This isn't a test that can wait around. A combination of techniques on these fresh samples, wet mounts, iodine stains, special trichrome stains, can collectively confirm the diagnosis in a high percentage of cases, maybe 75–95%.
Are there other, perhaps more sensitive ways to find them if those initial stool exams are negative?
Amoebic cultures are indeed more sensitive than direct microscopy, but they are generally not routinely available in most clinical labs, especially outside specialized reference or research settings.
What about looking inside?
If initial stool exams are negative, but suspicion remains high, a procedure like sigmoidoscopy, looking inside the lower colon with a scope, and taking biopsies from the edge of any observed ulcers can significantly increase the diagnostic yield. However, this procedure carries a notable risk of bowel perforation, especially if the patient has severe fulminant colitis, so it has to be done with extreme caution.
And for liver abscesses, are trophozoites found in the fluid?
It's important to remember that trophozoites are very rare in liver aspirates because, as we discussed, they're found primarily in the abscess capsule or wall, not in the necrotic, easily aspirated center. A negative aspirate doesn't rule out an amoebic liver abscess.
This really sounds like it requires specialized expertise to interpret these findings accurately. A real mastery is needed.
It absolutely does. Accurate microscopic diagnosis demands considerable experience. Trophozoites can be confused with neutrophils by an untrained eye, and the cysts must be meticulously differentiated morphologically from those other non-pathogenic Entamoeba species like E. hartmanni, E. coli, and Dolimax nana.
Why is that so important?
Because those non-pathogenic species don't cause clinical disease and, crucially, do not warrant therapy. Misidentification can lead to unnecessary treatment and side effects. And this is a critical point for professionals to master. The cysts of E. histolytica cannot be distinguished microscopically from those of E. dispar, E. mashkovsky, or E. bangladeshi. They look identical.
So how can you make the diagnosis microscopically?
Therefore, the microscopic diagnosis of E. histolytica as the definitive causative agent can only be made with certainty by detecting trophozoites that have visibly ingested host erythrocytes, red blood cells. That's the smoking gun under the microscope.
So if microscopy is that tricky, are there more modern, perhaps molecular or antigen-based tests available for definitive identification?
Yes, thankfully there are. More sensitive and highly specific tests have been developed for stool samples. These include enzyme immunoassay, or EIA, tests that detect that specific galgalnac lectin of E. histolytica, that unique attachment protein. That provides direct evidence of the pathogenic species. Additionally, multiplex polymerase chain reaction, or PCR, stool panels are now widely available. These can detect E. histolytica's DNA, rapidly and precisely identifying the parasite, and often differentiating it from the non-pathogenic species. These are critical tools for precise diagnosis now.
What about serology, those blood tests for antibodies? What role does that play in diagnosing invasive amoebiasis?
Serology is an incredibly important addition to the diagnostic toolkit, especially for invasive amoebiasis, things like colitis, amoeboma, and particularly liver abscesses. Specific antibody tests, like ELISA, are positive in over 90% of these invasive cases.
So they're pretty reliable.
Generally, yes. Positive results, when paired with the right clinical picture, usually suggest active or very recent disease. This is because these antibody levels typically drop and become negative within 6 to 12 months after successful treatment. Even in highly endemic areas, fewer than 10% of truly asymptomatic individuals have a positive amoebic serology, which helps distinguish active disease from past exposure.
Are all serology tests the same?
Well, older tests like the indirect hemagglutination test are a bit harder to interpret because the antibody levels, the titers, can stay positive for up to 10 years, so that's less useful for diagnosing an acute infection.
What if a serology test is initially negative, but the doctor still strongly suspects an amoebic liver abscess? Should they retest?
Absolutely, that's a key point. Up to 10% of patients with an acute amoebic liver abscess might initially test negative because their immune response hasn't fully ramped up yet. So if clinical suspicion is high, retesting after several days to maybe a week or two is highly advisable.
Okay.
Serologic tests are also invaluable for assessing the risk of invasive potential in those asymptomatic individuals found passing cysts, especially in non-endemic areas. It helps determine if they have the pathogenic E. histolytica or the non-invasive E. dispar. And, critically repeating that point about IBD,
Yes.
serologic tests should be performed in patients with suspected ulcerative colitis before starting glucocorticoid therapy to prevent those potentially catastrophic complications from unsuspected amebiasis.
Any newer developments in rapid diagnostics? Things that might be particularly useful in resource-limited settings?
Yes, there's some promising progress there. Recently, a technique called loop-mediated isothermal amplification, or MMP assay, was shown to be a potential alternative for directly detecting E. histolytica DNA, especially in pus samples from amoebic liver abscesses.
Why is LMP good?
The LAMP method is simpler, faster, and lower cost than traditional PCR. That makes it a potentially much better option for diagnosis in developing countries where sophisticated lab equipment might not be readily available. It could really improve accessibility and speed of diagnosis.
What about routine blood tests, like a complete blood count or liver function tests? Do they offer much insight into diagnosing invasive amoebiasis?
Routine hematology and chemistry tests are usually not very helpful in definitively diagnosing amoebiasis, as the findings are often pretty nonspecific.
Like what?
Well, about 3/4 of patients with an amoebic liver abscess will show leukocytosis and elevated white blood cell count, especially if symptoms are acute or complications have developed. But many infections cause that.
Okay.
Importantly, though, and this helps differentiate it from some other parasitic infections, invasive amoebiasis does not typically cause eosinophilia. You don't see a high count of eosinophils. Anemia, if present, is usually multifactorial.
And liver enzymes.
Even with large liver abscesses, liver enzyme levels are often normal or only minimally elevated, which can be misleading. Alkaline phosphatase is the one most often elevated, and it can stay elevated for months. Other liver enzymes, the aminotransferases, being elevated might suggest more acute disease or a complication, but they aren't consistently high.
What about imaging the organs, particularly the liver? How do radiographic studies help here?
Okay, radiographic barium studies, like a barium enema, are potentially dangerous in acute amoebic colitis because of the risk of perforation, so they're generally avoided in that setting. However, amoebomas, those mass lesions, might be first identified by a barium enema, but as we said, a biopsy is essential to differentiate them from cancer.
And for liver abscesses, what imaging techniques are most useful? Ultrasound, CT, MRI.
Ultrasonography, CT scans, and MRI are all incredibly useful for detecting the characteristic abscess. It usually appears as a round or oval, hypoechoic or low-density lesion, basically, a dark spot on the image.
Is there a typical location or number?
More than 80% of patients who've had symptoms for over 10 days typically have a single abscess, most commonly located in the right lobe of the liver. Approximately half of patients who've had symptoms for less than 10 days tend to have multiple abscesses, which can sometimes make them harder to distinguish from bacterial abscesses initially.
Are there specific imaging findings that might indicate complications are likely or have already occurred? Things clinicians should look out for.
Yes, definitely. Imaging findings strongly associated with complications include very large abscesses, say greater than 10 centimeters, especially if they're high up in the right lobe, near the diaphragm, as these are at higher risk of rupturing into the chest.
Okay.
Multiple lesions, as mentioned, raise the suspicion for pyogenic bacterial abscesses requiring differentiation. And critically, lesions in the left lobe of the liver are a particular concern because they have that potential to rupture into the pericardium around the heart. That's an emergency.
Right.
It's also important for clinicians managing these patients to know that the abscesses resolve slowly. Their size on imaging might even temporarily increase despite the patient clearly getting better clinically with treatment. So, frequent follow-up ultrasounds just chasing size can sometimes be confusing.
How long does resolution take?
Complete resolution of a liver abscess within 6 months can be expected in most patients, maybe 2/3. But about 10% might have persistent abnormalities on imaging for a year or even longer, even after successful treatment.
With such a wide variety of symptoms, how do doctors distinguish amoebiasis from other illnesses that might mimic its presentation? What's the differential diagnosis that a professional needs to work through?
Okay, for intestinal amoebiasis, the differential diagnosis is quite broad. It includes various bacterial diarrheas caused by common pathogens like Campylobacter, certain invasive E. coli strains, and species of Shigella, Salmonella, and Vibrio.
How do you tell them apart?
What helps astute clinicians differentiate amoebic colitis are several key features. Amoebic colitis typically presents with less prominent fever compared to bacterial dysentery. The stools are usually heme positive. And that distinctive paucity of neutrophils in the stool examination is a really important clue, alongside actually finding the amoebic organisms themselves.
And the connection to inflammatory bowel disease comes up again here in the differential, doesn't it?
It does, and it's a critical point to reiterate for any medical professional managing diarrhea or colitis. As we've stressed, amebiasis must always be meticulously ruled out in any patient suspected of having IBD before immunosuppressive therapy like steroids is started. Misdiagnosis can have devastating consequences.
For liver abscesses, what are the common conditions that can mimic an amoebic liver abscess?
Because of that wide variety of signs and symptoms, an amoebic liver abscess can easily be confused with things like pulmonary disease, like pneumonia or emphysema, gallbladder disease, cholecystitis, or really any febrile illness with few localizing signs, especially in travelers. Think malaria, typhoid fever.
So, who should be screened or strongly considered for an amoebic liver abscess, even if the symptoms are a bit vague?
The diagnosis should be strongly considered in members of those high-risk groups we mentioned. People who have recently traveled outside the U.S., especially to endemic areas, or individuals in institutional settings. Once imaging confirms there is an abscess in the liver, the most important differential diagnosis then becomes distinguishing between an amoebic abscess and a pyogenic or bacterial abscess.
How do clinicians definitively differentiate between those two, amoebic versus pyogenic?
Patients with pyogenic abscesses typically tend to be older. They often have a history of underlying bowel disease like diverticulitis or maybe recent abdominal surgery, which provides a clear pathway for bacterial spread to the liver.
Okay.
While amoebic serology is very helpful and often points towards amoebiasis as positive, sometimes aspiration of the abscess fluid is required. Sending that fluid for gram staining and bacterial culture is needed to definitively differentiate the two diseases, especially if the clinical picture or serology is ambiguous. Getting that distinction right is paramount for choosing the correct treatment.
Okay, now that we understand the enemy, how it causes damage, how to find it, what's the actual plan of attack? How is amoebiasis treated to achieve complete eradication and ensure the patient gets better?
The drugs used to treat amoebiasis are primarily classified based on their main site of action. We basically have two categories, luminal amoebicides and tissue amoebicides. And understanding this distinction is absolutely crucial for effective, comprehensive treatment. You need to hit both targets.
Okay, let's start with luminal amoebicides. What are they and how do they work?
Luminal amoebicides are drugs that are poorly absorbed from the gut into the bloodstream. This means they stay concentrated inside the bowel lumen. Their activity is primarily limited to the cysts and maybe some trophozoites that are living right there in the gut contents, close to the mucosa, but not deeply invaded.
Which drugs are these?
In the United States, only two such agents are widely available, iodoquinol and perimomycin.
And when are these luminal agents typically used in treatment?
Okay, the primary indications for using a luminal agent include eradicating any residual cysts in patients who have already been treated for invasive colitis or a liver abscess. This is essential to prevent a relapse and also to stop them from transmitting it further.
What about asymptomatic carriers?
They are also used for treating asymptomatic carriers who are found to be passing cysts. However, and this raises an important point for you, the listener, to really consider the majority of asymptomatic individuals who are found passing cysts are actually colonized with E. dispar.
The non-pathogenic one.
Exactly. Which, as we discussed, doesn't cause invasive disease and therefore doesn't technically warrant specific therapy. It is prudent, though, and generally recommended to treat asymptomatic individuals found passing cysts unless E. dispar colonization can be definitively demonstrated by those highly specific antigen detection tests that can differentiate between the species. If you can't prove it's dispar, you treat for histolytica.
Okay, that makes sense. And for the invasive forms of the disease, like the colitis or the liver abscesses, what's the go-to treatment then?
For invasive disease, we absolutely rely on tissue amebicides. These drugs are well absorbed, they reach high concentrations in the blood and tissues after you take them orally or get them intravenously. This allows them to effectively target the trophozoites that have invaded beyond the gut lumen into the tissues.
And the main drug is?
The development of the nitramidazole compounds, especially metronidazole, was a truly monumental advance in treating invasive amebiasis. Patients with amoebic colitis or liver abscess should be treated with either IV or oral metronidazole.
Any common side effects from metronidazole that patients should be aware of?
Yes, common side effects include things like nausea, sometimes vomiting, abdominal discomfort. It's also well known for causing a disulfiram-like reaction. Meaning patients must strictly avoid alcohol while taking it and for a few days after. Mixing metronidazole and alcohol can lead to severe nausea, vomiting, flushing, headache. It's very unpleasant. Another longer-acting imidazole compound, tinidazole, is also effective and available, often used for similar indications, sometimes with simpler dosing.
So once patients are treated with these tissue amebicides like metronidazole, are they completely cured? Or is there a crucial follow-up step needed?
This is absolutely crucial for ensuring complete treatment and preventing spread. All patients, whether they've been treated for invasive colitis or a liver abscess, must also receive a full course of therapy with a luminal agent after they finish their course of metronidazole or tinidazole.
Why is that? If the tissue drug worked.
The reason is that metronidazole, while excellent at clearing those tissue-invasive trophozoites, does not effectively eradicate the cysts that might still be hanging out in the bowel lumen.
The survival form.
Exactly. If these cysts remain, the patient is at risk of experiencing a relapse of the infection later on, or critically, they can continue to be an asymptomatic carrier, shedding cysts and transmitting the infection to others. You have to clear the lumen too.
Has resistance to metronidazole developed in E. histolytica? That's always a concern with widely used antibiotics or antimicrobials.
Well, while resistance to metronidazole has been successfully selected in the laboratory under specific experimental conditions, fortunately, it has not yet been found in clinical isolates taken from actual patients.
That's good news.
It is very good news for our current treatment strategies. Relapses, when they do occur clinically after treatment, are not uncommon and probably represent either a reinfection the person got exposed again, or, more likely, a failure to adequately eradicate the amoebae from the bowel lumen due to maybe an inadequate dose or duration of that luminal therapy, allowing cysts to persist.
What about treating liver abscesses specifically? Are there any differences in the approach compared to treating intestinal amebiasis?
Metronidazole remains the absolute drug of choice for amoebic liver abscesses. Those longer-acting nitroamidazoles like tinidazole and ornidazole have also proven effective, sometimes even used as single-dose therapy in some developing countries, simplifying logistics. Therapeutic failure rates with metronidazole for amoebic liver abscess are remarkably low, less than 1%, which is excellent.
You need combination therapy.
There's currently no evidence that combined therapy with two different tissue-active drugs is any more effective than using the single drug regimen like metronidazole alone, followed by the luminal agent, of course.
And the luminal agent, is that definitely necessary for liver abscess patients too, even if they don't have any active intestinal symptoms at the time?
Yes, it is absolutely essential. Studies, particularly in South Africa, involving patients with liver abscesses, demonstrated that a high percentage, about 72% of patients who did not have any intestinal symptoms, still had active bowel infection with E. histolytica when tested.
So they were silent carriers in the gut.
Exactly. Thus, all treatment regimens for amoebic liver abscess must include a subsequent course of a luminal agent to ensure eradication of those intestinal cysts. This prevents the patient from becoming an asymptomatic carrier, capable of further transmission, and also helps prevent rare recurrences of the liver abscess itself. Amoebic liver abscess rarely recurs if treated properly with both the tissue and the luminal agent.
How quickly do patients typically respond to treatment for a liver abscess? When should doctors expect improvement?
More than 90% of patients respond really dramatically and usually quite quickly to metronidazole therapy. You should see a noticeable decrease in both their pain and their fever within about 72 hours. That's a key indicator that the treatment is working.
When would aspiration of a liver abscess be necessary, as opposed to just relying on the medical therapy? This seems like a critical decision point for clinicians managing these patients.
Right. Aspiration of an amoebic liver abscess is generally only indicated in very specific situations, not as a routine procedure for everyone.
What are those situations?
Okay, they include 1. The need to definitively rule out a pyogenic bacterial abscess, particularly if the patient has multiple lesions or the clinical picture is ambiguous. 2. If there's a clear lack of clinical response, meaning pain and fever aren't improving within about 3 to 5 days of starting appropriate medical therapy. 3. If there's judged to be an immediate threat of imminent rupture of the abscess, perhaps because it's extremely large or pushing against the liver capsule. And 4, critically, the need to prevent the rupture of left lobe abscesses into the pericardium, given the catastrophic consequences. Some might aspirate those proactively.
Does aspirating the abscess actually speed up the healing process or improve the overall outcome for the patient?
No, surprisingly. There's no good evidence from clinical studies that routine aspiration, even of very large abscesses, up to 10 centimeters or so, actually accelerates healing or improves the overall outcome for the patient compared to medical therapy alone.
Okay.
Even if a liver abscess has already ruptured, percutaneous drainage using a catheter guided by imaging can often be successful in managing the collection. Actual open surgery is generally reserved only for those dire circumstances, like bowel perforation or that life-threatening rupture into the pericardium.
So finally, for amoebiasis, how do we prevent this widespread infection, both on a larger public health scale and for individuals, particularly travelers? What are the key strategies?
Okay, prevention. Amoebic infection is spread fundamentally by ingesting food or water contaminated with those hardy cysts. And since a single asymptomatic carrier can excrete an astonishing number, up to 15 million cysts per day, prevention really requires a two-pronged approach.
Zachar.
Firstly, widespread adequate sanitation infrastructure, meaning proper sewage disposal and access to clean water.
Yeah.
And secondly, targeted eradication of cyst carriage in identified carriers, especially food handlers, through appropriate treatment with luminal agents.
What are some practical, actionable tips for travelers visiting high-risk areas to minimize their personal risk of infection?
For individuals traveling to high-risk areas, infection risk can be significantly minimized by following some simple but effective measures. Avoiding unpeeled fruits and vegetables is key, as they might have been washed in contaminated water or handled by carriers.
Right.
Consistently using bottled water for drinking, brushing teeth, and making ice cubes is crucial. It's important to understand that E. histolytic cysts are resistant to the levels of chlorine typically found in tap water.
So chlorination isn't enough.
Not reliably for these cysts. Therefore, if bottled water isn't available, disinfection by iodination, using compounds like tetraglycine hydroperiodide tablets, is recommended for treating water. Boiling water vigorously for at least 1 minute also works. Unfortunately, at present, there is no effective chemoprophylaxis, no pill you can take beforehand to prevent amoebiasis infection. Vigilance with food and water is key.
The unseen dangers infection with free-living amoebae.
Okay, now we're shifting gears quite dramatically. We're moving from amebiasis, a common, albeit serious and usually treatable infection, to something far more rare but truly terrifying. Infections caused by free-living amoebae. What exactly are these organisms, and why are they often considered such hidden killers?
Right. Well, they're still protozoans. These are distinctly different characters from Entamoeba histolytica. There are multiple genera, multiple types of free-living amoebae out there in the environment. But the main ones that cause human disease that we really focus on are Acanthamoeba, Naegleria, and Balamuthia. What's fascinating and deeply concerning for any medical professional is that all three of these parasites have the ability to cause serious central nervous system infections, infections of the brain and spinal cord, which are almost always fatal. That's why they get labeled hidden killers. They're often unrecognized until it's far too late.
Where do these dangerous amoebas typically live in the environment? Are they just everywhere?
Acanthamoeba and Naegleria are distributed pretty much globally. They've been isolated from an astonishingly wide variety of fresh and brackish water sources.
Like what?
Common places like tap water, lakes, rivers, hot springs, even swimming pools, if not properly maintained.
Yeah.
But they also thrive in more unexpected spots. Think heating and air conditioning units, cooling towers, humidifiers, even hospital water networks. They've even been found just hanging out in the nasal passages of healthy children without causing problems. Their remarkable ability to form cysts, similar to Entamoeba, allows them to protect themselves from drying out in periods when food is scarce. It makes them incredibly resilient environmental survivors, just waiting for the right conditions to become active again.
And I've heard they can even harbor other dangerous pathogens inside them. That sounds like a significant environmental role, almost like a Trojan horse.
Yes, that's a critical and often overlooked aspect of their ecology. The persistence of Legionella pneumophila, the bacterium that causes Legionnaire's disease, in water systems, is partly due to its ability to live and multiply inside free-living amoeba, particularly Acanthamoeba.
So the amoeba protects the bacteria.
Exactly. And recent lab studies suggest that several other pathogens that are resistant to being killed by our immune cells might be able to survive and maybe even multiply within water systems by hiding inside these free-living amoebae.
Like what other pathogens?
Things like Pseudomonas aeruginosa, various non-tuberculous mycobacteria like Amebium complex, Amebiasis, and potentially even some viruses. This truly highlights their profound role as environmental reservoirs and potential vectors for other dangerous microbes. It significantly complicates infection control and public health efforts, especially in water systems.
What about Balamuthia? Is its environmental home similar to the others, like in water?
In contrast to the predominantly aquatic environment preferred by Acanthamoeba and Naegleria, the main environmental niche for Balamuthia mandrillaris appears to be soil.
Soil.
Yes. In fact, a soil sample from a flower pot was definitively linked to a fatal infection in a child once. Cases of Balamuthia infection have been reported from all continents except Africa, but the majority seem to originate from warm, dry areas like the southwestern United States and parts of Latin America. This suggests specific climatic and soil conditions might favor its presence. It's a key difference to remember Balamuthia is more associated with soil and dust.
Have we seen any new risk factors or ecological niches emerge for these free-living amoebas in recent years? This seems like important evolving knowledge for professionals.
Yes, absolutely. With increased awareness and much better diagnostic capabilities, we are identifying additional, sometimes surprising risk factors and ecological niches. For example, since around 2010, several cases of Naegleria fowleri infection, the classic brain-eating amoeba, have been reported from northern U.S. states.
Where it used to be rare.
Exactly. Areas where it was previously thought to be too cold. And interestingly, some of these cases have been associated with exposure to treated, piped municipal water, rather than just natural lakes or rivers. This suggests a potentially concerning new ecological niche for Naegleria, maybe linked to warming water temperatures or aging infrastructure.
Wow. What else?
Since 2009, there have been 3 clusters of Balamuthia mandrillaris infections tragically associated with organ transplantation.
Transplant.
It indicates a very rare but possible route of transmission, likely from an infected donor organ to the recipient. And Acanthamoeba species, as we'll discuss, have been responsible for large outbreaks of microbial keratitis, that's severe eye infection, overwhelmingly linked to contact lens wear and specifically improper lens hygiene. These are significant shifts in understanding how these pathogens interact with us.
Okay, let's dive deeper into Naegleria infections first. What exactly is primary amoebic meningoencephalitis, or PAM, and just how devastating is it?
Primary amoebic meningoencephalitis, PM, is indeed a fulminant, meaning incredibly rapid and severe central nervous system infection caused specifically by Naegleria fowleri, and it was almost uniformly fatal. Between 1962 and 2015, for context, about 133 cases were reported in the U.S.
That sounds very rare.
It is extremely rare. The annual number of reported infections has remained relatively stable, usually between 0 and maybe 8 cases per year nationwide. However, those recent changes in the epidemiology we mentioned, particularly the geographic spread, are definitely a cause for concern for public health officials.
What are those recent changes in PAM epidemiology that are raising concerns, especially with things like climate change?
Okay, so from 2010 to 2015, there were 24 CDC-confirmed cases reported. What was particularly notable, alarming even, was that in 2010, PM was reported for the first time ever from a northern state, Minnesota.
Minnesota?
Yes. And that was followed by additional cases from Minnesota, Indiana, and Kansas in the following couple of years. This really raises the important question. With the effects of climate change potentially leading to higher water temperatures in more places, could other previously unaffected areas increasingly be at risk for Naegleria fowleri infections?
That makes sense.
The remaining cases during that period were, as expected, mostly from southern states with traditionally warmer climates. It just highlights how environmental shifts might alter disease patterns for even these rare infections.
Who tends to get this infection? Is there a typical profile in terms of age or gender? And how are they usually exposed?
Well, in that 2010-2015 cohort, about 63% of cases affected female patients, though whether that's a true susceptibility difference or just chance in small numbers is unclear. The median age of patients was quite young, typically around 11 years old, although the range spanned from young children to middle-aged adults.
And exposure.
The vast majority of these patients, nearly 80%, were exposed during recreational activities in freshwater, primarily swimming or diving in lakes, reservoirs, rivers, streams, or ditches, consistent with typical summertime activities.
Okay.
The remaining 5 cases, about 21%, were linked to tap water exposure. This happened through things like using contaminated tap water for nasal irrigation with a neti pot, playing on a backyard slip and slide using hose water, or swimming in a poorly maintained swimming pool that likely used contaminated source water. It highlights how easily people can inadvertently encounter this amoeba.
So once someone is exposed, how does this amoeba manage to get into the brain to cause such a severe infection? What's the actual pathway?
PM typically follows the forceful aspiration or insufflation of water contaminated with the Naegleria fowleri trophozoites up into the nasal passages. This usually happens during activities like swimming, diving, or jumping into warm fresh water.
Okay.
Once in the high nasal passages, the amoeba invades the olfactory neuroepithelium, that's the specialized lining responsible for our sense of smell. From there, it rapidly migrates along the olfactory nerves, which pass directly through the base of the skull, straight into the brain.
Wow, a direct route.
A very direct route. Infection is most common in otherwise healthy children or young adults after swimming in warm lakes or poorly maintained heated pools. And as we noted, in those rare instances, cases occur when contaminated tap water is used for nasal irrigation, effectively bypassing the natural protective mechanisms of the nose.
What are the symptoms of PM, and how quickly does this devastating infection progress? This seems critical for any chance of early recognition.
After a relatively short incubation period, typically just 2 to 15 days after exposure, patients rapidly develop severe headache, high fever, nausea, vomiting, and meningismus stiff neck, signs of meningitis.
Other signs?
Other common neurological signs include photophobia, extreme sensitivity to light, and palsies of cranial nerves 30, 4, and 6, which control eye movements. The progression is frighteningly rapid, often leading to confusion, hallucinations, seizures, and coma within just a few days.
How fast is death?
Sadly, the prognosis for PAM is uniformly poor. Most patients die within about a week of symptom onset, often within just 3 to 7 days, due to massive brain swelling, herniation, and destruction of brain tissue.
How is PAM diagnosed then, especially when it progresses so rapidly?
Right.
Quick identification seems absolutely crucial for any chance of intervention.
Okay, the diagnosis of Naegleria infection should be strongly considered and suspected in any patient who presents with symptoms of acute purulent meningitis, meaning infected, cloudy spinal fluid, but for whom routine lab tests show no evidence of bacteria on gram staining, antigen tests, or culture.
So meningitis, but no bacteria.
Exactly. That's a huge red flag. Other findings in the cerebrospinal fluid, CSF, often resemble fulminant bacterial meningitis, very high intracranial pressure, extremely high white blood cell counts, mostly neutrophils, elevated protein, and very low glucose levels.
How do you confirm it's PAM?
The definitive diagnosis of PAM depends on detecting the motile Naegleria trophozoites directly in a wet mount preparation of fresh spinal fluid. This requires immediate microscopic examination by an experienced technician. The Amebae die quickly.
What about other tests?
It's important to note that antibodies to Naegleria are found in many healthy adults, so serologic testing isn't useful for diagnosing acute infection. However, specialized diagnostic PCR tests and histochemical staining of brain tissue are available through the Centers for Disease Control and Prevention, CDC, for confirmation, highlighting the need to involve public health labs early.
What are the treatment options, given the incredibly grim prognosis you described? Is there any hope at all, especially with newer agents coming online?
A number of antimicrobial agents do show activity against Naegleria fowleri in laboratory settings, in vitro. But despite this, translating that into clinical success has been incredibly difficult, and the prognosis for patients remains extremely poor in practice.
Who has survived?
The few documented survivors of PM worldwide have typically been treated with various aggressive combinations of drugs, often including high-dose intravenous and sometimes intrathecal directly into the spinal fluid amphotericin B, along with azoles like fluconazole, azithromycin, and rifampin. These are often desperate kitchen sink approaches, given the urgency and poor outlook.
But there's this new hope, miltefosine, you mentioned it earlier.
Yes, there is a significant new hope that is changing treatment protocols. The repurposed anti-parasitic agent miltefosine, originally developed for cancer and leishmaniasis, has shown promising activity in the lab against Naegleria and also Acanthamoeba and Balamuthia.
Is it available?
This drug is now available in the U.S. directly from the CDC under an investigational new drug protocol for compassionate use in these rare infections. To date, among the handful of patients globally who have received miltefosine as part of their treatment for Naegleria infection, there have been a few survivors, some with complete recovery, some with significant neurological deficits, and unfortunately, many still died despite receiving it.
So it's not a magic bullet, but part of the picture.
Exactly. The key insight for professionals is that since around 2013, when miltefosine became more readily available through the CDC, it has been administered to both of the two known surviving U.S. patients with PAM and several others who ultimately died. Its inclusion is now considered a critical component of aggressive combination therapy.
So what's truly key then to improving outcomes for this devastating infection? What's the takeaway for medical professionals on the front lines?
The current understanding, the consensus, is that incredibly early diagnosis, suspecting it quickly, is paramount, followed by immediate, aggressive combination therapy that includes miltefosine and intensive management of the neurological complications, like brain swelling, often involving therapeutic hypothermia, are all critical factors.
So speed and expertise matter.
Immensely. This raises an important directive for clinicians. Any physician whose patient might have PAM should immediately contact the CDC Emergency Operations Center. They offer 204/7 consultation, assistance with rapid diagnostic testing via PCR, and provide urgent access to miltefosine and the latest treatment recommendations. Timeliness is absolutely paramount. Every single hour counts in PAM.
Okay, let's move on to Acanthamoeba. This one seems to have a more drawn-out course compared to Naegleria and affects different people, I understand.
That's correct, and it's a key differentiating factor that professionals must recognize. Infection with Acanthamoeba species generally follows a much more indolent or slow-progressing course compared to the explosive onset of Naegleria PM. And importantly, it typically affects chronically ill or otherwise debilitated, often immunocompromised patients. This is quite different from Naegleria, which often strikes otherwise healthy individuals. This difference in host susceptibility is a crucial diagnostic clue.
Who specifically is at risk for these serious Acanthamoeba infections, particularly the brain infection, which I think is called granulomatous amoebic encephalitis, or GAE?
Right, GAE. Risk factors for developing serious Acanthamoeba infections, including GAE, commonly involve underlying conditions that significantly compromise the immune system. These include things like lymphoproliferative disorders, cancers of the immune system, like leukemia or lymphoma, patients undergoing chemotherapy, those on long-term glucocorticoid therapy, steroids, people with autoimmune diseases like lupus erythematosus, and certainly patients with advanced HIV infection or AIDS are at significantly increased risk. Pretty much any condition that weakens the immune system can open the door for this opportunistic pathogen.
How does Acanthamoeba reach the brain then? And what are the typical clinical signs of GAE?
Acanthamoeba infection usually reaches the central nervous system hematogenously, meaning it travels through the bloodstream from a primary site of infection somewhere else in the body. This initial site could be the sinuses, the skin, or the lungs.
Okay.
Once it gets to the CNS, the onset of GAE is typically insidious, gradually developing over weeks to months, unlike the rapid progression of PAM. The resulting syndrome can be quite variable, but commonly includes symptoms like persistent fever, headache, altered mental status, confusion, lethargy, and focal neurologic signs.
Like what kind of focal signs?
These can manifest as cranial nerve palsies, affecting eye movement or facial muscles, problems with balance and coordination leading to ataxia, or weakness on one side of the body known as hemiparesis.
Are there any other unique symptoms or signs that might be present, especially in immunocompromised patients like those with AIDS, that could help with diagnosis?
Yes, particularly in AIDS patients who develop disseminated Acanthamoeba infection, characteristic cutaneous ulcers or hard nodules containing the amoeba are frequently detected on the skin. These skin lesions can be a very important diagnostic clue.
Why are they important?
because they provide a much more accessible site for biopsy compared to the brain. Identifying the organism in a skin lesion can sometimes lead to the diagnosis before the neurological symptoms become severe, potentially allowing for earlier treatment initiation.
How is granulomatous amoebic encephalitis, GAE, diagnosed then, particularly given its variable and insidious presentation? This sounds really challenging.
It is very challenging. Examining the cerebrospinal fluid for the trophozoites or cysts can sometimes be helpful, but they may be sparse and difficult to find. Plus, performing a lumbar puncture to get CSF might be contraindicated if there's evidence of significantly increased intracerebral pressure, which is a common and dangerous complication of GAE.
What about brain imaging?
Imaging, like CT or MRI scans of the brain, is crucial. Scans frequently reveal single or multiple lesions. These might appear as areas consistent with embolic infarcts, suggesting blockage of small blood vessels, or as multiple ring-enhancing lesions with surrounding edema, which can actually mimic the appearance of cerebral toxoplasmosis, another common opportunistic infection in AIDS patients.
So, how do you get the definitive diagnosis?
The definitive diagnosis really comes from directly demonstrating the characteristic trophozoites and double-walled cysts of Acanthamoeba in tissue, usually from a brain biopsy specimen, or sometimes from skin or sinus biopsies if lesions are present there. Culture on special non-nutrient agar plates seeded with bacteria like E. coli can also be helpful for growing and identifying the amoeba. And again, specialized fluorescein-labeled antibody staining is available through the CDC for rapid detection in biopsy specimens.
Does having AIDS specifically impact the course or severity of GAE caused by Acanthamoeba?
Yes, it significantly impacts the course and unfortunately makes it even more dangerous. GAE in patients with AIDS may have an accelerated and even more rapidly fatal course compared to other immunocompromised hosts, with survival sometimes measured only in weeks, maybe 3 to 40 days after symptom onset.
Why is it faster in AIDS patients?
It's thought to be primarily because these individuals have profound difficulty forming those protective granulomas, the organized collections of immune cells, that are essential to try and wall off and contain the infection in other hosts. Their severely compromised immune system simply cannot mount an effective localized defense, leading to rapid, unchecked proliferation and destruction of brain tissue.
And what about treatment for Acanthamoeba infections, including GAE? Are there any effective therapies available?
Various antimicrobial agents have been tried over the years to treat Acanthamoeba infection, often in combination. But success has unfortunately been limited, reflecting the difficulty of treating this resilient parasite, especially its cyst form. However, as with Naegleria, miltefosine, available from the CDC, should now be considered a core component and included as part of combination therapy for Acanthamoeba infections due to its promising activity. Multi-drug regimens, often including agents like pentamidine, sulfadiazine, flucytosine, and azoles, are typically necessary, but outcomes remain challenging.
Now, Acanthamoeba also causes a severe eye infection, right? Acanthamoeba keratitis. That seems like a very different manifestation from the burn infection.
This is where it gets really interesting for a different and, frankly, much more common reason clinically. The incidence of keratitis, which is a potentially blinding inflammation of the cornea, the clear front part of the eye caused by Acanthamoeba, has actually increased significantly in the past few decades.
Why the increase?
It's thought to be partly due to just better diagnosis and increased awareness among ophthalmologists. But critically, it's also due to changing risk factors. Historically, Acanthamoeba keratitis was often associated with direct trauma to the eye, like getting dirt or contaminated water splashed in it. Now, however, the vast majority of infections, particularly in developed countries, are directly linked to contact lens wear. Rare cases have also been associated with LSI eye surgery.
So contact lens wearers really need to be particularly careful with their lens hygiene then. This sounds like a key takeaway for many listeners.
Absolutely. Contact lens wearers are by far the group at highest risk for Acanthamoeba keratitis. Key risk factors identified in numerous outbreaks include using homemade saline solutions instead of sterile commercial ones, topping off old solution instead of replacing it, wearing lenses while swimming or showering or in hot tubs, and generally inadequate disinfection practices.
How do the lenses contribute?
It's presumed that contact lenses themselves can cause microscopic trauma to the delicate corneal surface, providing an entry point for the amoeba if the lenses or solutions are contaminated. Early symptoms can be quite nonspecific, maybe just tearing, redness, light sensitivity, or the painful sensation of having something in the eye. But once the infection becomes established, progression can be rapid and very painful, posing a serious threat to vision.
What's the characteristic sign that an ophthalmologist might look for in Acanthamoeba keratitis to make that critical diagnosis?
The characteristic clinical sign that often raises high suspicion for Acanthamoeba keratitis is an annular or ring-shaped infiltrate or opacity in the cornea. This distinctive ring, called a stromal ring infiltrate, represents a corneal abscess, a collection of inflammatory cells and necrotic tissue within the corneal layers itself. While not always present, when seen, it's a strong indicator of Acanthamoeba. Deeper corneal invasion, ulceration, and severe vision loss may tragically follow if the infection isn't diagnosed and treated aggressively and early.
How is Acanthamoeba keratitis diagnosed definitively? And importantly, how is it treated, given the notorious resistance of the cysts? This sounds like a really difficult management challenge for eye doctors.
The differential diagnosis for infectious keratitis is broad. It includes bacterial, fungal, mycobacterial, and herpetic viral infections. So getting a definitive diagnosis is crucial. The irregular polygonal double-walled cysts of Acanthamoeba, which are quite distinctive under the microscope, may be identified in corneal scrapings or corneal biopsy material taken directly from the infected eye.
Can you grow it?
Yes. The trophozoites can also be grown on special culture media, often non-nutrient agar overlaid with bacteria, to confirm the diagnosis. Confocal microscopy, a specialized imaging technique, can sometimes visualize the cysts directly in the living cornea.
And treatment.
The challenge with treatment is that those cysts are notoriously resistant to many available antimicrobial drugs. Medical therapy results have historically been disappointing and often require prolonged treatment, sometimes for months, with combination topical agents. Some agents used include biguanides like PHMB or chlorhexidine, often combined with diamidines like propamidine isethionate or hexamidine. Severe infections frequently require surgical intervention, such as therapeutic keratoplasty, a corneal transplant, to remove the infected tissue and save the eye or restore vision. It's a very difficult infection to manage successfully. Early diagnosis is key.
Finally, let's explore the third major player here, Balamuthia mandrillaris. What's its story? How was it first identified?
Okay, Balamuthia mandrillaris. It's another important free-living amoeba that causes GAE. It was first identified back in 1986 as the cause of a fatal brain infection in a mandrill baboon at the Wild Animal Park in San Diego, California, hence the species name mandrillaris.
And where does it live?
The parasite has since been isolated from soil and dust samples, suggesting that unlike Naegleria and Acanthamoeba, which favor water, Balamuthia's primary niche is likely soil. It's probably widespread in the environment, though its exact distribution isn't fully mapped. It's now recognized as an important, though rare, cause of granulomatous amoebic encephalitis, GAE, in humans, similar in pathology to Acanthamoeba GAE, as well as causing cutaneous skin lesions and sometimes sinus infections.
Are there specific risk factors for GAE caused by Balamuthia that have been identified?
Yes. The California Encephalitis Project, which has looked at many cases of encephalitis of unknown origin, identified several potential risk factors for GAE caused specifically by Balamuthia mandrillaris. These include young age, the presence of immunocompromising conditions, though it can affect healthy people too, and interestingly, Hispanic ethnicity seemed overrepresented in their cohort. This highlights the importance of considering demographics and specific vulnerabilities.
And the organ transplant connection for Balamuthia, you mentioned clusters. That's where it gets really interesting, offering a profound insight into its transmission. How does that happen?
This is truly a critical insight into Balamuthia transmission, particularly relevant for those involved in transplant medicine. The infection likely often starts with percutaneous exposure, perhaps through a skin wound contaminated with soil, or maybe mucous membrane exposure, like inhaling contaminated dust. From that initial site, it's thought to spread hematogenously, through the bloodstream, to the brain, and potentially other organs. This pattern of dissemination precisely explains the risk for transmission through solid organ transplantation.
How is that discovered?
In 2009 and 2010, two distinct clusters of organ transmitted B. mandrillaris infections were detected. This was a remarkable feat of public health surveillance. It was recognized by identifying severe, unexpected neurological illness developing in multiple recipients who had received organs from the same donor, usually after an incubation period of about 17 to 24 days.
So the donor was infected?
It showed that the organism could be silently present in the donor, perhaps as a subclinical infection, and then transmitted via the transplanted organ, causing severe, often fatal GAE in the immunosuppressed recipients. It added a whole new dimension to transplant safety considerations.
Does Balamuthia only affect immunocompromised people then, or can it infect healthy individuals too? This seems important for a broader understanding.
No, interestingly, and this is a key difference from Acanthamoeba GAE, Balamuthia frequently affects immunocompetent individuals, including healthy children and adults. The course of Balamuthia GAE is typically subacute, meaning it develops over weeks to months, similar to Acanthamoeba. Symptoms often include focal neurologic signs, fever, seizures, and persistent headaches, usually leading to death within about a week to several months after the onset of symptoms.
Any other signs?
Skin lesions, similar to those sometimes seen with Acanthamoeba, may also occur on the face, trunk, or extremities in Balamuthia infections, providing another potential diagnostic clue. And beyond just dust inhalation, inoculation of the trophozoites or cysts from stagnant water or soil through open wounds or mucous membranes is also thought to be a possible route of exposure.
How is Balamuthia diagnosed given its rarity and varied presentation? This must be very challenging for clinicians to even think of.
Diagnosis is indeed very challenging. Examination of cerebrospinal fluid usually reveals findings similar to other forms of chronic meningitis or encephalitis, typically an increase in white blood cells, sometimes mononuclear, sometimes neutrophils, elevated protein levels, and normal to low glucose concentrations. However, the amoebae themselves are rarely isolated or seen directly in the CSF.
So CSF isn't usually diagnostic.
Not usually definitive on its own. Brain imaging studies, like MRI scans, are crucial and usually detect single or multiple ring-enhancing lesions, often in the posterior fossa or cerebrum. The definitive diagnosis typically relies on identifying the amoeba in tissue, usually from a brain biopsy, using specialized stains or immunohistochemistry. Specific fluorescent antibody tests and PCR assays for Balamuthia are also available through the CDC. Getting tissue is often key.
And what about treatment for Balamuthia infections? Are there any successful therapies given the typically serious prognosis?
The prognosis for Balamuthia GAE remains very poor. But unlike PAM, there have been a number of documented survivors, offering some hope. The handful of surviving patients in the United States and globally have typically been treated with aggressive long-term combination therapies using a variety of drugs.
Which drugs?
Commonly used agents have included pentamidine, fusitidine, sulfadiazine, azithromycin or clarithromycin, and azoles like fluconazole or vorconazole. Critically, the CDC now strongly recommends that miltefosine be included as part of the combination treatment regimen for Balamuthia infections, just as it is for Naegleria and Acanthamoeba, due to its demonstrated activity against this parasite as well. Early, aggressive, multi-drug therapy gives the best chance.
What other conditions could Balamuthia GAE be confused with? What's in the differential diagnosis that a professional needs to consider?
The differential diagnosis for the brain lesions seen in Balamuthia GAE is important. It includes things like tuberculomas, which are brain lesions caused by tuberculosis, neurocysticercosis, parasitic infection caused by tapeworm larvae, common in some parts of the world, fungal abscesses or granulomas, primary brain tumors or metastases, and even bacterial abscesses. All of these can present with similar neurological symptoms and somewhat similar imaging findings, necessitating careful evaluation, often including biopsy, for accurate diagnosis and appropriate treatment. Getting the diagnosis right is crucial.
Outro.
Wow. Okay, today we truly took a deep dive, maybe even a plunge, into the fascinating, complex, and yes, sometimes terrifying world of these protozoal infections. We journeyed from the really widespread Amebiasis, caused by Entamoeba histolytica, all the way to the rare but often deadly free-living amoebae like Naegleria, Acanthamoeba, and Balamuthia. Yeah, we really covered the gamut. We explored their intricate life cycles, tracing their paths from environmental sources right into the human body. We dissected how they cunningly evade our immune systems, the remarkably diverse ways they can present clinically, from silent carriage to fulminant brain infections.
Right. And we looked at the sophisticated methods needed for accurate diagnosis, which often requires specialized tests and expertise, and the critical strategies for effective treatment, including knowing which drugs target which stage or species.
And by understanding these profound nuances, really getting into the weeds on things like the specific virulence factors like the galgalnac-alectin and E. histolytica, or the devastating speed of PAM, or the critical life-saving role miltefosine now plays in treating free-living amoeba infections, and the absolute necessity of differentiating morphologically identical but genetically distinct species like histolytica and dispar. You just gain the kind of deep granular knowledge that elite professionals in this field truly value. It's about recognizing those subtle signs others might miss, appreciating the profound diagnostic challenges, and understanding the highly targeted treatments required for these formidable microscopic invaders. You have genuinely achieved a mastery-level understanding of the core concepts in Chapter 223.
As we wrap up this deep dive, then, maybe consider this thought. These tiny, often invisible organisms really highlight just how incredibly interconnected our immediate environment is with our fundamental health. They also remind us just how much there is still to discover about the vast microbial world that exists alongside us and even within us.
That's a great point.
So, what does the increasing recognition and, in some cases, the changing prevalence of some of these infections, especially thinking about shifting climates with Naegleria or changing behaviors like contact lens use with Acanthamoeba, what does that tell us about our ongoing and often unseen battle with this microscopic world?
It tells us we need constant vigilance, constant learning. The world of infectious diseases constantly reminds us that knowledge isn't just power. It is a vital tool for health, for prevention, and ultimately for survival. Keep exploring, keep questioning. There's always more to understand.